Hi, this is Dr. Anisha Malhotra.
And I'm Dr. Colin Danko. Welcome to our 5-part series, Billing and Coding, the reimbursement basics for emergency physicians and what you need to know.
This is part 3 of a 5-part series, brought to you by Dallas Emergency Medicine.
In this video, part 3, we will review the exam code 99291. This code represents care provided by a physician for critical care, and for our specialty, it is the CPT code we would use when we provide care in the emergency department for critically ill patients.
At the end of this review, you should be able to explain the required documentation in your H&P for a 99291 critical care chart, and you should know the level of complexity needed in your medical decision-making.
And how to thoroughly document that medical decision-making. In Part 1, we talked about the CPT codes 99281 through 99285. The majority of your earnings as an emergency physician, about 85%, will come from CPT codes 99281 through 99285.
But about 3 to 6% of your earnings will come from critical care. In those cases, you'll be using a 99291 CPT code.
And that 3 to 6% is not a small amount. Here you can see that a 99291 critical care CPT code has a value of 6.28 relative value units, or RVUs.
And with each RVU worth about $36 for a Medicare patient, 6.28 relative value units translates to about $226. Privately insured patients will pay higher, assuming that you document correctly, of course.
Now that you know 3 to 6% of your money will be earned by the critical care code 99291, you need to know what differentiates this code from others. Current Procedural Terminology, or CPT, and the Center for Medicare and Medicaid Services both define 99291 care similarly.
A critical illness or injury acutely impairs one or more vital organ systems such that there is a high probability of imminent or life-threatening deterioration in the patient's condition.
So, we need to document correctly so we can properly charge critically ill patients.
Recall from Part 1 in this series, there are 2 main areas that determine the level of service. Your H&P and your medical decision-making are critical in coding properly. Remember to think of medical decision-making as your lab, imaging, and treatment orders. And those elements will be important for this higher and more complex level of coding.
For your H&P, you need to document 4, 10, 20, 8. Or 4 historical elements, 10 review of systems, 2 elements in the past medical, social, and family history, and at least 8 organ systems examined in your physical exam. As a memory aid, think of the 2 small shotgun shell sizes, 410 and 28.
Remember, especially with critical care patients, that parts of the history, review of systems, and the past history can be unobtainable. The patient may be too ill to communicate, so document that fact in the appropriate areas so your chart can still qualify for a 99291 CPT code.
You are not expected to obtain all elements from a comatose patient.
Now that you have documented your 4, 10, 28 in your H&P, what about MDM, or medical decision-making?
Your MDM, or medical decision-making, will need to justify that your patient is critically ill, and that patient required interventions to support any vital organ system failure.
Specifically, you want your documentation to state decision-making of high complexity to assess, manipulate, and support vital organ system failure and or prevent further life-threatening deterioration of the patient's condition.
This exact wording appears in the Common Procedural Terminology Standard and is also recognized by the Centers for Medicare and Medicaid Services, what we know as CMS.
Besides your 41028, you will need to document some specifics to help your coders understand your medical decision-making. You have to remember that a minimum of 30 minutes has to be spent treating that patient, and that patient only. It can be cumulative over several hours. It doesn't have to be 30 contiguous minutes.
Many facilities use a template to help the physician enter all the required information for a 99291. Here's one example of a template. With little manipulation, any emergency physician can make it fit their preferences and local patterns. We fill in the spaces occupied by asterisks with specifics.
For example, 37 minutes of critical care,
A heart rate of 158 and concern about cardiovascular injury from the rapid rate.
list the diagnosis of atrial fibrillation with rapid ventricular response and a comorbidity of hypertension,
Diltiazem IV for control of the atrial fibrillation,
and include treatment results, with a rate decrease to 108, and so on. This template is just an example of documentation to help your coder understand your critical care actions, and it backs up your 37 minutes of critical care time.
You may decide to write this information out in a paragraph and avoid a template, but the emergency physician needs to understand what the coder will be looking for in your documentation, and what many payers require. Don't worry if you go beyond 30 to 75 minutes of time providing critical care. Remember to still document your total time. Your coder can also bill for increasing amounts of time when you exceed the 75 minutes covered by the 99291 CPT code. Now, when do we want to think about critical care and documentation to back it up? Here's a good thing to remember. When any patient is sick enough for the nurse to interrupt you for immediate evaluation, that patient might be a 99291 critical care patient.
Typically on every shift, the emergency physician has to halt their work when a nurse grabs them to see a presenting patient who is extremely ill. So keep that in mind. Patients sick enough to interrupt your typical workflow might qualify as 99291 critical care.
Yes, I'd agree that interruption of workflow is a good indicator. You can look at his face like that. While being grabbed by a nurse may mean something else. So how about some examples of critical care patients in terms of diagnoses?
Some good examples that come to mind are acute ischemic stroke, intracranial bleeding, and patients in status from seizures.
Examples of cardiac disease include pulmonary edema, atrial fibrillation with rapid ventricular rate, or unstable arrhythmias like ventricular tachycardia or type 3 complete atrioventricular block.
Septic shock requiring pressors, necrotizing fasciitis, or meningitis should qualify for critical care with typical intervention and documentation.
Certain IV medications will qualify with good documentation. Diltiazem for rapid atrial fibrillation, epinephrine for anaphylactic shock, heparin for embolism or acute coronary syndrome, insulin for diabetic ketoacidosis, or norepinephrine for shock.
Interestingly, IV insulin is often simply overlooked by emergency physicians working in high acuity facilities as an indicator of critical care. And on the list goes, too long to try to commit to memory.
That's enough for now. Let's review. A 99291 critical care chart should include a thorough history and physical exam, a 4-10-28.
The H&P should be followed by complex medical decision-making that includes your lab, imaging, and EKG interpretation. IV medications, especially controlled narcotics and other dangerous drugs, should be clearly documented to help your coders. We suggest a template that includes most of the elements the coder is looking for to justify a claim for critical care.
And last but not least, remember to think about critical care documentation when you are pulled away for a patient that has a disease threatening one or multiple systems.
That's it for now, folks. Thanks for watching, and stay tuned for more episodes on billing and coding, the reimbursement basics for emergency physicians and what you need to know.
Signing off from Dallas, Texas, this is Dr. Colin Danko
and Dr. Anisha Malhotra.